Good evening friends, welcome to my channel Critical Care Basics, and in this channel, as we all know, we are running ECG tutorial, and this is the 39th ECG tutorial. Today's topic is, I'm afraid, is going to be a little lengthy. I tried to make this into 2 videos, but the topic is very important. All the doctors and the nurses sometimes find it difficult to diagnose a wide complex tachycardia, and usually there is less time because such patients are either critical or rapidly become critical. So if the patient comes in an emergency department or ICU with wide complex tachycardia, how do we diagnose as to whether this is ventricular tachycardia, supraventricular tachycardia, or something else? So let's start. Approach to diagnosis of wide complex tachycardia. Part 1. You are sitting in the emergency department and a patient comes with palpitation, and this is the ECG. So how can you tell? The QRS complex is wide. It is almost slightly more than 120 milliseconds or 3 small squares. And now you have to diagnose whether it is VT or SVT, and the treatment of both is different. Let's see another example. A 27-year-old woman comes with palpitation. As soon as ECG is taken, initial 2 beats are narrow complex sinus beats. Then suddenly she develops a wide complex tachycardia. Then how do we approach this patient? Right? So these are the scenarios that you will face in ICU sometimes, and they can be very tricky. So let's dive into this topic. I'll go a little slow and there will be repetitions, so kindly forgive me for that. But that will help to drive the concepts home. So let's start with wide complex tachycardia. As soon as the patient lands into an emergency department with palpitations or near pre-syncope, and you see a wide complex tachycardia in ECG, you don't have a lot of time to spend in diagnosing this patient, but you have to take a short focused history. What you have to find out is whether the patient has a history of structural heart disease, like coronary artery disease or previous MI. In that case, it becomes very likely that this is a ventricular tachycardia. If the patient already has an ICD, it is more likely that it becomes more likely that the patient has VT. If the patient has a pacemaker in situ, then it could be pacemaker-induced ventricular tachycardia. If the patient has a known atrial fibrillation, is a known patient of atrial fibrillation, and now presents with a regular wide complex tachycardia. So if the patient of AF, normally patient of AF will have an irregular rhythm, right? Irregularly irregular. But if such patient, known patient of AF, presents with a regular wide complex tachycardia, then it is likely to be a ventricular tachycardia. Unless there is an exception. If sometimes this AF organizes into a flutter with wide complex low heart rate, especially in patients who are taking class 1C antiarrhythmics like amiodarone or dronedarone. Regarding age, if the patient is more than 35 years of age, there is 80% chance, 85% chance that this tachycardia could be ventricular tachycardia. Likewise, if the patient is younger, then it is more likely that this tachycardia is a supraventricular tachycardia, unless the patient has family history of ventricular tachycardia or history of sudden cardiac death in family. Symptoms are not useful in diagnosing whether this is VT or SVT, but they are helpful in indicating the severity. The patient has syncope, that means that there was significant fall in cardiac output. Now, many medications can cause VT or wide complex tachycardia. So they could have proarrhythmic effects, which can be directly due to prolongation of QT interval or indirectly by alteration in the electrolyte. So obtaining a medical history is among the first priorities in the evaluation of a patient with wide complex tachycardia. The most common drug-induced wide complex tachycardia is a polymorphic VT called torsades-de-Pons. Right, this arrhythmia is associated with QT interval prolongation in sinus rhythm. Many medications, I have already talked about this complex torsades-de-Pons in my earlier videos, so I will not go into a detailed drug list of torsades, but antiarrhythmic drugs anti-infective drugs and psychotropic drugs, especially tricyclic antidepressants, are known to prolong QT interval and they pose a risk of torsade, right, polymorphic ventricular tachycardia. And as we just discussed, class 1T and 1C antiarrhythmic drugs like amiodarone or dronedarone can sometimes organize atrial fibrillation into a slow flutter with wide complex and 1:1 transmission, which may mimic a VT. So this is an ECG in a patient who was taking tricyclic antidepressant, and you see wide complexes. So this QRS is very wide, so really wide. So these are the small 5 squares and 2 more, so about 0.4 into 7, so it is more than 200 milliseconds wide. And when such wide complex tachycardia is seen, I would recommend you to see a YouTube video by Dr. Mattu on wide complex tachycardias, because as per ACLS guidelines, if such patient is stable and you give amiodarone, that will be a clean kill, the patient will die immediately. So if you see really wide complex tachycardia, think about drugs and think about hyper K, that is hyperkalemia, and give calcium and soda bicarb, right? So if the patient does not have hyper K or tricyclic antidepressant toxicity, nothing will happen to the patient. But if that is the case, the patient, you can see in front of your eyes the tachycardia becoming narrow QRS. So remember, very wide complex tachycardia, think about drugs and think about electrolyte imbalances. Physical examination, do a short physical examination to see whether the patient has some structural heart disease, like whether there is a sign of heart failure, acute or chronic, there are Krebs, whether the patient is hypoxemic, and whether there is an incision, healed incision of the sternum, suggesting that he underwent a cardiac surgery, or there are sequelae of peripheral arterial disease or stroke, example surgical scars of vascular surgery or residual neurological deficits. And pacemaker or ICD, usually pacemaker or ICD is in the infraclavicular region, sometimes even in the anteroabdominal wall. So if the patient has some of these, then you could get an idea that this is more likely to be a ventricular tachycardia. This is the classic algorithm for treating or diagnosing any patient with complex tachycardia in ICU or in emergency setting. So we divide tachycardias into narrow and wide as per the QRS duration. So QRS duration more than 3 small squares. Each small square is 40 milliseconds. So 3 small squares more than 120 milliseconds. So if it is 120 milliseconds or more, then it is called wide complex tachycardia by definition. If it is less than 120 milliseconds, that is called as narrow complex tachycardia. Then each of these is further divided into regular and irregular. So we have 4 classes. First is narrow complex regular tachycardia. In this we have sinus tachycardia, inappropriate sinus tachycardia, AVRT, AVNRT, that is AV nodal reentrant tachycardia, atrioventricular reentrant tachycardia, focal atrial tachycardia, atrial flutter, junctional tachycardia, SA node reentrant tachycardia, and rarely VT. As we have seen in our last lecture of NSVT, that left ventricular idiopathic tachycardia has a relatively narrow QRS complex and it also responds to verapamil. So that may mimic a narrow complex tachycardia. So rarely VT has a narrow complex tachycardia. Among the irregular narrow complex tachycardias, we have atrial fibrillation, multifocal atrial tachycardia, sinus tachycardia with frequent atrial ectopics, focal atrial tachycardia or atrial flutter with variable block. Our topic today is wide complex tachycardia. So if wide complex tachycardia is regular, then it is monomorphic ventricular tachycardia or SVT with aberration, or it is ventricular pacing or electrolyte abnormalities, especially hyper K and antidromic AVRT. If it is irregular, then it could be atrial flutter or atrial fibrillation or focal atrial tachycardia with aberrant conduction, atrial flutter or atrial fibrillation or focal atrial tachycardia with antegrade conduction, or polymorphic VT including torsade, or antidromic AVRT with nodoventricular or nodofascicular pathway with variable ventriculoatrial conduction. So now, having said that, what do we do? You are sitting in the emergency department and a patient comes with, say, palpitation or pre-syncope, and in ECG you get a wide complex tachycardia. So all patients with wide complex tachycardia should have a brief assessment of symptoms, vital signs and level of consciousness to see whether the patient is stable or unstable, hemodynamic stability, and simultaneously start oxygen, get a venous access, send blood for appropriate samples, liver function, kidney function, electrolytes, routine investigations, and attach the patient to, if the patient is taking on drug, also send drug levels, attach the patient to a continuous cardiac monitor and take a proper 12 lead ECG with a rhythm strip. A wide complex tachycardia can be a challenge to diagnose and to treat because diagnosing the arrhythmia is difficult. Although most wide complex tachycardias are ventricular tachycardias, the differential diagnosis includes a variety of supraventricular tachycardias. So diagnostic algorithms can differentiate these two etiologies. We'll come to that. And these diagnostic algorithms are complex and imperfect. Also, we don't have time because urgent therapy is often required. Patients may be unstable at the onset, or if the ventricular rate is very high, more than 200, they could rapidly deteriorate. They could rapidly become unstable. So we have to treat urgently. So this makes it a little difficult to immediately diagnose and treat wide complex tachycardia. So what the first thing that you do is to assess for hemodynamic instability. The patient could come in one of the three classes. Either the patient is unstable as hemodynamic compromise, patient could have hypotension or altered mental status, patient could be obtunded or drowsy and may complain of chest pain or may have rate related heart failure. So, but generally remains awake and has a discernible pulse. Patient is hypotensive, a slightly drowsy but has a pulse. So that means the patient is not in cardiac arrest but has a pulse but has hemodynamic instability. Such patient requires emergency cardioversion after giving sedation. Second category of patient is pulseless VT, wide complex tachycardia with absent pulse. So such patient will be treated as cardiac arrest. So you have to follow the ACLS guidelines, cardiac arrest algorithm. Lastly, the patient is stable. Patient has wide complex tachycardia, but you can see the BP. BP may be slightly lesser, but it is above 90/60, say about 160 or 110 BP. Patient is not obtunded, patient is not in heart failure. So here you get time to take a proper ECG, take a rhythm strip and try to diagnose. This is a fallacy. The presence of hemodynamic stability should not be regarded as diagnosis of supraventricular tachycardia. So misdiagnosis of VT as SVT based on hemodynamic stability is a common error and that can lead to inappropriate and potentially dangerous treatment. The upper ECG is SVT and the lower is VT. They look very similar. So it is very difficult to immediately in an emergency to diagnose and properly treat. In most patients, first step is you make up your mind as to what is the initial diagnosis. Is it VT, is looking like VT clinically as well as ECG wise, and by closely looking at the ECG, and definitive diagnosis will follow later. 12 lead ECG and a rhythm strip. If there are any questions about the stability, if you think that patient is borderline hemodynamically unstable, then detailed description or detailed analysis of ECG can wait. The patient requires urgent cardioversion. Now, once you have seen that the patient is stable and the patient has wide complex tachycardia, you have to assess, and your assessment starts with the rate. So rate is not very helpful because there is a wide range of heart rate in wide complex tachycardia. But if you see a rate about 150, you may probably think that it is a flutter with 2:1 conduction. Second is regularity. VT is generally regular. Slight variation in the heart RR interval can be seen, but if it is regular, it is more likely to be VT. And when the onset of arrhythmia is available, you can see the initial sinus rhythm and the beginning of VT. When that onset is available, if there is period of some irregularity and then acceleration, what is called as a warm-up phenomenon, then it is more likely to be a VT. Now, once you have seen a wide complex tachycardia, the key is to see lead V1. So in lead V1, if you see a strong positive complex like this one, so it is called RBB like pattern. It is not RBBB, but it is RBBB like pattern, right? Just remember this, because this is going to help us in the algorithms later. While if there is predominantly QS pattern lead V1, then this looks like LBBB, so this is called LBBB pattern, right? So first we saw about the rate, which is not very helpful, then the rhythm and the pattern. Let's go ahead. Then comes the axis. If you see right superior axis, what is called as northwest axis, that is between -90 to +180, the axis going this way. So if that is the axis, it is very likely that the arrhythmia is a ventricular tachycardia, right? There are two exceptions. First is antidromic AVRT, because here the ventricular pre-excitation and the ventricular there is direct activation of ventricular myocardium. So the axis goes, the depolarization process from down upwards like this. So you can have a northwest axis. We'll see the examples. And the second is a biventricular pacemaker. If there is a northwest axis, then it is more likely to be a VT. Now, if you have a ECG for comparison, previous ECG, and now the patient presents with wide complex tachycardia, if the patient has a RBBB like wide complex tachycardia, and now the axis has turned leftward more than -30, then it is likely to be VT. Similarly, if it is a left bundled branch block type pattern on wide complex tachycardia and the axis is +90, which was not there earlier, so that will suggest that this is VT. So here see negative complexes in 1, 2, 3 and strongly positive complexes in AVR. So this is suggestive of northwest axis and wide complex tachycardia. So this is VT, and this patient was cardioverted, and now you see the axis has come back to normal. So if the patient has northwest axis and a wide complex tachycardia, it is likely to be ventricular tachycardia. Another example, northwest axis. So this is more likely to be a ventricular tachycardia. Whenever there is biventricular pacing, pacer tracing here, and in this you see tall R wave in AVR. So in biventricular pacing there could be northwest axis. So these are the two exceptions for a northwest axis in a wide complex tachycardia for ventricular tachycardia. The next point that we see is the QRS duration. By definition, any QRS duration more than 120 millisecond is called wide complex tachycardia, right? In general, the wider the complex, more likely it is to be a ventricular tachycardia. So in RBBB like wide complex tachycardia, if the QRS duration is more than 140 milliseconds, and in LBBB type wide complex tachycardia, if the QRS duration is more than 160 milliseconds, that is 4 small squares, it is likely to be VT. So in analysis of several studies, if the QRS duration is more than 160 milliseconds, that is 4 small squares, there is 20:1 chance that this wide complex tachycardia is a VT. But there are 4 exceptions to this rule. One is SVT with an AV accessory pathways. So SVT with WPW syndrome. So this is an exception. If the patient is taking class 1 sodium channel blocking antiarrhythmic drugs, so QRS can be wide. If the patient has hyperkalemia, potassium more than 7, so QRS will become significantly wide. And lastly, the patient has DCM with fibrosis, so marked slowing in impulse conduction could cause a wide QRS. And contrary is not true. If the QRS is less than 140 milliseconds, that does not mean that this is not a ventricular tachycardia. So that does not exclude ventricular tachycardia, as the tachycardia arising from the septum and his Purkinje system can be relatively narrow. The next thing that we have to see is concordance. What is concordance? Concordance is present when QRS complexes in all 6 precordial leads, that is V1 to V6, the chest leads, shows monophasic complex with same polarity. We will see the examples like all complex positive or all complex negative. If all complexes from V1 to V6 are all leads from V1 to V6 show tall positive complexes only, then that is said to be positive concordance. Similarly, if all the complexes from V1 to V6, all the leads from V1 to V6 shows strong negative complexes, monophasic, then it is said to be negative concordance. So, negative concordance, that is V1 to V6 entirely negative with deep monophasic QS complexes, is strongly suggestive of VT, but rarely SVT with left bundle branch block aberrancy can cause negative concordance. Similarly, positive concordance, V1 to V6 entirely positive tall monophasic complexes, is again likely to have VT, but antidromic AVRT can cause such positive concordance. Again, like I said about the QRS duration, positive concordance suggests VT, but if there is no positive concordance or no concordance, that does not mean that it is VT. That does not rule out VT. So if there is no concordance, that does not mean this is not VT, right? Here you can see all the complexes are negative, right from V1 to V6. The monophasic negative complexes, broad white QRS tachycardia. So this is called as negative concordance, and this is likely to be VT. Exception is SVT with LVV aberrancy. And this is positive concordance, right from V1 to V6 all the leads are showing tall R waves. So this is again likely to be VT. Exception is antidromic AVRT with left posterior accessory pathway. The next thing, we have seen the rate, the rhythm, then the QRS duration, the axis, the concordance, and the next point that you have to see, AV dissociation. AV dissociation is characterized by atrial activity that is independent of ventricular activity. Atrial activity means the P waves. They are independent of ventricular activity. There is no connection. Usually with a ventricular rate exceeding the atrial rate. The QRS rate is higher than the atrial rate. When identified on ECG, the presence of AV dissociation largely establishes VT as the diagnosis. So if you see AV dissociation on ECG, you can say that this is probably more likely to be VT. Though not always present, fusion beats and capture beats are readily recognized in AV dissociation. We will see what are the fusion beats and capture beats. In wide complex tachycardia with AV dissociation at an atrial rate, that is the P wave, slower than the ventricular rate, strongly suggests ventricular tachycardia. An atrial rate that is faster than ventricular rate is seen with many SVTs. If the atrial rate is faster, for example, the patient has flutter with 2:1 block. So atrial rate faster than the ventricular rate is seen in many supraventricular tachycardias, atrial flutter, atrial tachycardia with 2:1 AV conduction. So there is no, in that case there is no AV dissociation. So that is the point to be noted. Now see, this is a wide complex tachycardia, and here you see narrow complexes, 2 narrow complexes coming. So these are the supraventricular complexes which have managed to depolarize the ventricles. In between these have managed to capture the ventricles. That's why this is called, these are called capture beats. And sometimes ventricles are depolarized partly by the supraventricular impulse and partly by the ventricular impulse. So you get a wave that looks something between this and this. So that is called a fusion wave. So if you see capture waves and fusion waves, then probably that confirms AV dissociation, and it makes ventricular tachycardia as a cause of wide complex tachycardia very likely. So here you can see the sinus rhythm, PQRST, PQRST. Suddenly the patient develops wide complex tachycardia, and you see the P waves here. This is the P wave here and the P wave here. So the P waves are coming at regular intervals, but the QRS has come, wide QRS is coming at very fast interval. So there is no relation with the QRS and the P waves after the patient starts this wide complex tachycardia, and the QRS rate is much higher than the P rate. So this is AV dissociation, and this confirms that this is ventricular tachycardia. Absence of AV dissociation does not rule out VT. Again, if you do not see AV dissociation in a wide complex tachycardia, that does not mean that this is VT, because AV dissociation may be present but not obvious. We'll see the examples. In some cases of VT, the ventricular impulses conduct backwards through the AV node and capture the atrium. So there is sometimes VA conduction, referred to as 1s2 retrograde conduction. So in fact that is AV association, not dissociation. This may be seen more commonly when the rate of ventricular tachycardia is slower. VT with retrograde ventricular conduction or 2:1 ventricular atrial conduction technically does not exhibit AV dissociation, right? In all cases where there is VA conduction, ventricular atrial conduction, you will see inverted or retrograde P waves. Dissociated P waves. P waves are said to be dissociated if they are not consistently coupled with the QRS complexes, as evident by the following. PP and RR intervals are different. These are the PP intervals and these are the RR intervals. So they are different. Then PR intervals are variable. Interval between this P and this R and this P and this R is different. So PR intervals is different. There is no association between P and QRS. So P waves and QRS are not associated, and the presence of P wave with one or more but not all QRS complex. So you can see P wave with this QRS complex, but here you do not see P waves. So all the criteria are fulfilled with this ECG. So these are dissociated P waves, which indicate that the patient has AV dissociation. During a wide complex tachycardia, P waves are often difficult to identify, but many times it is difficult to identify P waves. If P waves are not evident on the surface ECG, you can take esophageal ECGs. We'll see the examples. In this patient was initially in sinus rhythm and developed wide complex tachycardia, and patient also had esophageal electrode in place. In esophageal electrode, the P waves are seen like these spikes. So these, see the spikes here, the P waves were not evident. You can see this. Now that you know that the P waves are seen on the esophageal ECG, you can see that this small change in shape, this small change in shape was in fact a P wave. But had you not seen this esophageal lead, you probably do not see P waves here. So probably AV dissociation was not evident. But now you see that there are P waves, and the Q wave rate or R wave rate is much faster, and there is no association between the PR intervals are changing, no association between the QRS complex and the P waves. That means this is a ventricular tachycardia. This patient had a surgery and there is a directly epicardial electrode in place, again showing tall spikes as P waves, again showing AV dissociation. This is a repetition slide. Again, fusion and capture beats when identified on surface ECG in a patient with wide complex tachycardia are diagnostic of VT. So when you see fusion and capture beats, that means this is AV dissociation and this is wide complex tachycardia is VT. Fusion beats occur when one impulse originating from the ventricle and second supraventricular impulse simultaneously activate ventricular myocardium. So this is a ventricular beat. This is a ventricular beat, and this is a capture beat. So when these two together depolarize the ventricle, you get something like a fusion beat. The resulting QRS complex has a morphology which is intermediate between the sinus beat and the ectopic, ventricular ectopic. Intermittent fusion beats during wide complex tachycardia are diagnostic of AV dissociation. That means diagnostic of ventricular tachycardia. Capture beats, also called as Dressler's beats, are QRS complexes during the wide complex tachycardia that are identical to the sinus QRS complex. So this is a capture beat. The term capture beat implies that normal conduction system has momentarily captured control of the ventricular activation from the VT focus. So here we have seen how to approach a patient with wide complex tachycardia, and how will you come to know whether this is a ventricular tachycardia or a supraventricular tachycardia. In next lecture we will see various algorithms to diagnose ventricular tachycardia from supraventricular tachycardia in a wide complex tachycardia. So kindly see this lecture properly so that you can understand the next one. Thanks a lot. If you are liking these videos, please like, subscribe and share. Bye bye.